Hello, everyone. And on behalf of myself and my Bioethics Center colleagues, I'm excited to welcome you to the Children's Mercy Bioethics Center Alumni Speaker Series. For those who don't know me, I'm Stephanie Kokora. I'm one of the core faculty in the Bioethics Center and the Director of Bioethics Scholarship. As you may know, this series features some of our outstanding graduates of our certificate program in pediatric bioethics and the Pediatric Bioethics Fellowship here at Children's Mercy. Today, I'm delighted to introduce an outstanding alum who I'm proud to call a colleague and friend. Tanya Arora. Hi, Tanya. Her practice has included pediatric palliative care, hospital-based care of children with medical complexity, clinical bioethics, global health, and health equity. So, she has lots and lots of free time, not busy at all. In Tanya's work as an educator, she has used medical improv, narrative medicine, cultural humility, and community engagement to strengthen communication and connection in healthcare relationships. She was in the 2021 to 2022 Children's Mercy Certificate Program, where her project was to consider how we develop morally safer spaces in healthcare settings to interrogate bias and discrimination. So I'm very excited for this talk, Tanya. Maybe I'm biased because you and I have a lot of the same interests, but I love hearing you speak, and I'm so excited that you're joining us today.
Thank you so much. I'm so excited to be here. If you all out there don't already have a friend like Stephanie Kokora, get one. Not only do we have overlapping interests, but she also is the type of person who says my name when I'm outside of the room, and I really appreciate that so much. I'm really feeling very honored to be able to speak to you all today about a topic I care so much about. I will just very quickly review the objectives. What I hope to do today is just talk a little bit about implicit bias and then talk about cultural humility as a way of navigating around those biases. And then hopefully we come together to a conclusion that interrogating bias is essential to the creation of moral communities in healthcare. I'm going to actually start with an interactive exercise, which is tricky over this town hall. So there are some people who have the ability to unmute, and others, most of us, won't be able to unmute. I would ask that if you are watching this live or watching this later in the recording, that you actually just participate along with this exercise, saying this color out loud. Whether you can mute or unmute on the call is sort of less important than just doing the exercise together. But for those of you who are able to unmute, I'm going to say 3, 2, 1, go in a second. And when I do, I just want to make sure that we can hear your voices, okay? So I'll have you say hello when I say 3, 2, 1, go. All right. So unmute if you are able to. And 3, 2, 1, go. Hello.
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 Perfect. Okay, so stay unmuted. For those of you who are not able to unmute, that's okay. You're going to do the exercise right alongside with us. So all I'm going to ask you to do, those letters, they don't really mean anything, right? X, Y, Z. I want you just to read the color that you're seeing in the vertical columns all the way down. So for example, what we'll do is all together, I'll say 3, 2, 1, go. And then all together, we'll say red, green, purple, yellow, blue, blue, purple, green, red, all the way down in vertical columns until we get to the last blue. Sometimes the instructions in my head are much clearer than the ones that I verbalized. For those of you who have to do this unmuted, any questions?
Nope, let's do it.
All right. All right. So I'm going to say 3, 2, 1, go. And then whether you are muted or unmuted, we're just going to all say the colors together. 3, 2, 1, go. Red,
green, purple, yellow, blue, purple, green, red, yellow, red, blue, green, purple, green, blue, yellow, red, purple, green, yellow, blue.
Brilliant. That was perfect. Okay, since we did that so well, that was just the warm-up. We're going to do it again, this time as fast as we can. So red, green, purple, yellow, blue, purple, green, red. All right, I'm going to say 3, 2, 1, go. And as fast as we can, we're just going to read the colors out loud. 3, 2, 1, go.
Red, green, purple, yellow, blue, purple, green, red, yellow, red, green, purple, blue, yellow, red, purple, green,
yellow, blue.
Brilliant. That was so good. We're going to do it one more time. This time, just like we did the last time, we're just going to say the color that we're seeing out loud. So red, green, purple, yellow, blue, all the way down in vertical columns. So I'm going to say 3, 2, 1, go. And we'll just say the color that we're seeing out loud. All right. 3, 2, 1, go.
Red, green, purple, yellow,
purple,
blue,
yellow,
green,
blue, purple, green, red, yellow, yellow, red, blue, green, purple, green, blue, yellow, purple, red, purple, green, yellow, blue.
purple, red.
All right. Give yourselves a round of applause because that is not easy. I really appreciate you all participating. If you were unmuted, go ahead and you can put yourself back on mute. That exercise just demonstrates that when we have a tight association together, that things should match up, right? You look at that slide and it's like, what kind of trickery is Tanya doing to us? When the color is blue, the word should read blue. When the color is red, the word should read red. But this isn't matching up. This is implicit bias. It is when we have a tight association in our head that when something occurs, something else occurs with it. I want to just acknowledge that this exercise is maybe not as useful if you have difficulty differentiating between red, blue, purple, green, yellow. But the teaching point, the learning point is the same. When we have a tight association of two things together, it is hard for us to separate them out. It's not impossible. You heard either in yourself or you overheard the very brave participants who unmuted. You heard that we could pull it apart, right? We had to do a lot of work, but we were able to say red when we saw red. But it did take us some time to pull those apart. I oftentimes think in that moment of hesitation, when we can pull two things apart, what our brain is working overtime. And you'll see as we got to that last two columns, it was even harder to pull those associations apart. We were tired. We'd read all of those words already. We were getting to the end, and it was just harder to do that cognitive work of pulling it apart. We might have also already realized we got a couple of things wrong. And so now at the end, it's like, oh, I've already gotten this wrong. I'm not feeling great about myself. I'm not feeling confident, and I'm tired. Just to draw that into a patient care example. So sometimes we have tight associations that have formed about people as well. So I think about a patient coming in with a pain complaint. If they are a teenage minoritized male, is my first thought pain, or is my first thought drug seeker? And if my first thought is drug seeker, even if I am able to rip apart that association, there might be a millisecond of hesitation that the patient sees on my face as I hesitated to pull apart that association. And then what's happening for the patient themselves in that moment as I hesitate is, I think that they must be wondering, can I trust this advice that's coming at me? Does it make sense? Is it meant for me? Does the practitioner believe in their advice that they're giving? And so I just want us to think for a moment about how tight those associations are and the amount of work that it takes to separate them. I also want to point out one of the things that I said is that as we got to the end of the table, we were tired from reading. We might be tired from being short-staffed. We might be tired from being overworked. We might be tired from having lived through a global pandemic. There are all sorts of reasons we rely on cognitive shortcuts. And so those are times when there's been a lot of research to show that our implicit bias comes out more. That exercise is borrowed from Jerry Kang, who, when he does this exercise, when I've heard him do this exercise, he says after running us through this exercise, I really don't care that you have implicit bias. We all have it. That is not how I measure you as a person. How we measure each other is what are we going to do about it? So just to review, implicit biases are subconscious and automatic. I deliberately use the word subconscious. Sometimes you hear them referred to as unconscious biases, but unconscious would imply that we can't bring them into our awareness, that we can't perform actions upon these biases, whereas subconscious is they are present with us as we are actively moving around the world, and they have the potential to cause harm. We know that they are pervasive. Everybody has biases. We also know that these biases do not align with our explicit beliefs. This is especially an important point in healthcare, I think, because so much of our professional identity is tied up with this idea of being a good person. And certainly someone who um, who discriminates against others, we would maybe put that in a bad person definition. And so it's very hard for us to acknowledge that we might have biases within us that we are valuing in a binary good or bad. We know that implicit bias has real world effects, including in healthcare. I had mentioned that implicit bias is often a cognitive shortcut. Maybe this last point is the most important to me, that implicit biases are malleable. We can change them. The nicest thing about being human beings is that we are curious and that we're constantly learning and growing. So the biases and associations that we have formed just from living as human beings in our world can be expanded upon, can be unlearned, and can be replaced with new mental associations. I apologize for my froggy voice. I had lost my voice yesterday and it's just now coming back. I'm going to take a sip of water. So we all have biases, but it's really hard for us to talk about them. And when I think back, so if we think back to like over 20 years ago now, the Institutes of Medicine published a report to Err is Human. And in this report, they talked about medical errors as the leading cause of death, as one of the leading causes of deaths in the United States, exceeding the deaths from motor vehicle accidents, breast cancer, and AIDS. And hospitals reacted to this. This was horrifying information. You might remember the analogy that was drawn was it was the equivalent to 2 to 3 jumbo jets full of people dying in the United States every day just from medical errors. And so nearly all hospitals now have surveillance systems for these types of major hospital-acquired infections. In fact, the rate of central line-associated bloodstream infections has fallen by about 80% since the publication of To Err is Human. And if you just think about wandering through the hospital or the clinic on a regular day, you'll see in terms of medication errors that people are wearing those neon vests or those fluorescent straps to indicate, don't interrupt me, I am doing math. Or we have ways to double check our medications, or technology has been leveraged to make ordering medications safer. We check for the computer helps us check for allergies, contraindications, dosing ranges, and helps provide suggestions for if we've gotten something wrong. We also have barcoding systems. So there's a barcode on the medication, then there's a barcode on the patient wrist, and they both get scanned so that the right medication goes to the right patient. About 20 years ago, the Institute of Medicine also published Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. And in this report, they identified longstanding racism as a major reason for health disparities. And yet there remains no meaningful progress for decreasing those health disparities. This report showed that differences based on race and ethnicity were present even when controlling for differences caused by systemic disenfranchisement. So when we think about access or insurance status, poverty, opportunity, or education, this report controlled for all of those factors and still found that individual bias, prejudice, and stereotyping on the part of healthcare practitioners was contributing to differences in care. And so there have been small efforts, really important efforts, healthcare navigators, community health workers, healthcare coaches. There's increased awareness in healthcare disparities. And we haven't really moved the needle. So when we think back to Err is Human, which came out around the same time, looking at medical errors, and that report asserted that the problem is not bad people. It is that we are people working in healthcare, good people who are working in bad systems, and those systems need to be made safer. And that propelled research, a whole field of quality improvement, tons of funding, highly effective interventions, all dedicated to patient safety. When confronted with the data, the healthcare system transformed itself. But we haven't been able to transform ourselves when it comes with the harms associated with our own biases. Concerns about bias, prejudice, discrimination, they are heard differently. I think it's very hard for us to hold that we can be biased and working within a biased system and still be good people. I will say that the teachings of anti-racism help guide us to understand that having bias is just a function of being a human being and having a human brain. And it is just our way of sorting and understanding the world around us. Anti-racist theory doesn't judge us for having bias, but encourages us to identify our biases and then seek to consciously and consistently work towards equity. The title for this talk, Lovely Families, comes from a piece that I wrote now several years ago called A Lovely Family. And it really was starting from my learning around anti-racism and critical race theory, that the place to start interrogating biases within myself. What are my own beliefs, my values, my experiences, and how do I bring that into the patient room, both for good and for harm? I will also say that I learned through experience that I was not successful at running around calling everyone else a racist. That did not work. I do not recommend that as a strategy, or at least it didn't work for me. But what seemed to work is if I started with acknowledging the limitations in my own perspective. I'm not going to read the whole story, but maybe I'll tell you a little bit about it. So, what had happened was, it was sort of, I'm a palliative care practitioner, and it was later in the day. Most of the team had dispersed for the day, either to go home or to finish up writing notes. And it was just myself and the social worker. There was one more patient left to see. We said, let's just go run and see that patient. This was a 5-year-old girl. The oncology team had called in the morning to say, please see them. So we said, okay. And we walked into the room. It was a mother, a father, and this 5-year-old girl. She was sitting on the floor playing with her toys. And we sat by the couch as the sun set behind the parents in this hospital room. And we talked about her. So she had been diagnosed 2 days earlier with an inoperable and incurable brain tumor. And the parents had, over the past 48 hours, talked about really understanding that their time with her would be limited, and really thinking about how they, and more importantly, how she wanted to spend that time. Understandably, as we talked, her mom started to cry, and this little 5-year-old girl with her long, wavy, golden colored hair, it was that type that has ringlets at the bottom. And this little girl crawled into her mother's lap and wiped away her tears and said, "It's okay, Mama." And the social worker and I left the room. And as we closed the door, we turned to each other with tears in our eyes and said, what a lovely family. I don't know that there was anything else to say at that moment. The plan was clear. There was nothing really to discuss. The parents had been so clear in how they wanted to spend this time. So we said that, and then we walked back to our office. And as we walked back to our office, as you do, you debrief the day, think about what you did, what work is left to do, what you're going to do the next day. And as we did that, I was struck by the fact that all the families we had seen that day were lovely families. But I hadn't said that when walking out of all of the rooms. What was maybe most striking to me was the first patient that we had seen that day. The same oncology team had called us and they said, we really need you to see this family today. The mother is refusing surgery and chemotherapy for her son. She is angry, they told us. She is in denial. She doesn't trust us. She's aggressive. All of these were code words that helped me to know that this mom is a Black woman before I ever walked into the room. So at the urgent request of that team, that same social worker and I had gone in to see this patient actually as the first patient in the morning. And as we entered the room, this mom and her son were sitting on his hospital bed and they were laughing together. And he welcomed us into the room, and this super charming, sweet teenage boy. And we joined them in their joyful mood. And over time, we started talking, and he shared his understanding of his illness, and mom shared her understanding of treatment options. She also shared her worries and fears about surgery and chemotherapy. At some point during the conversation, the patient asked if he could take a nap. So the social worker and I moved over with mom to that side couch, and we talked. And as we talked, she shared a little bit about her son, including asking if we would watch a video of his 8th grade graduation. So we watched this video of him. He was valedictorian, and he gave this beautiful speech, and the video finished, and she asked if we would watch it again. And so we watched it again. This young boy giving this amazingly dynamic speech in his button-down shirt and his bright blue tie. And as we reflected on our day's work, as we walked back to our office after seeing that last family, I realized that I had not walked out of that visit and said, what a lovely family, although they were certainly a lovely family. And I wondered, why didn't I say that they were a lovely family? And what would that difference mean for how I would hold them, how I would think about them, how I would advocate for them, and how I would care for them? That piece resonated with folks in a way that I suppose I didn't expect. And I always wonder why it resonates. And I think maybe it is because I'm starting by looking inwards, which is much safer maybe than looking at other people and saying, look at your racism. What I'm saying is, look at my racism. And yet I also know that the only way I know about my knowledge gaps is with help from other people to say, to help notice when I do or when I don't call someone lovely. So I need that feedback. And I think about that report to Air is Human. I may think I'm dosing penicillin correctly, but I do need the help of my team member to double check. I do need the computer system to alert me that there's an allergy. I do need the pharmacist to double check my dosing. And when all those systems help to correct my knowledge gap, I'm not mad about it. I'm grateful. I might even say, that was a close call. Thank you so much. But I can't seem to do that about my own biases. This slide goes with credit to Hannah Song, who ran the office at CHLA, formerly known as DEI, now called Opportunity, Integrity, and Impact. And in this slide, she gives us some reminders of when I feel like I'm being called a racist, things to do. Take a breath. It's always good advice. Understand that this may not be about me as a person, but just something in my actions revealed a gap in my knowledge. Acknowledge that it might not feel good to hear this, but I do have agency over my ability to affect change. She also encourages being curious. So to the person who is calling you in, tell me more. I want to figure this out. I'm confused by what you said. Can you explain it to me again? And she reminds us about the importance in focusing to get it right, not being right. I've added this last thing, which I've been really lucky in my life experience and in my career to get feedback. And when I have received feedback, I really try to hear it as an act of love. So if someone is giving me feedback, that is hard to do. It takes time, it takes courage, it takes thoughtfulness. They are only doing that because they care about me. They're only doing that because they think I can do better, because they see that I'm worth it. When we are calling someone in, so when you recognize or when you're concerned that someone has a gap in their knowledge, Dr. Song encourages us, see something, say something, lead with empathy. So be compassionate, knowing we've all made mistakes. We will all continue to make mistakes. We do need help from each other. We can ask a question. What did you mean by that comment? What information are you basing that on? Be curious. Tell me more about that type of thinking or what you're thinking. I'm confused about what you said. Can you explain it to me again? And then I know it wasn't your intent, but that made me uncomfortable. And I would add here, again, giving feedback is also an act of love. I love and care about you, and I want you to hear my perspective. And so I'm going to take this time with my courage and share it with you. So when I hear, am I being called a racist? Yeah, maybe, because we all have a little bit of that inside of us. Can I reframe that to understand that what is being said is it possible that my lived experience and acquired knowledge just has gaps in it that can be helped by the perspectives of others? And I hope that one day, in response to hearing someone else bring up concerns that I have a knowledge gap, that I can turn around and say, whew, thank you so much. That was a close call. So why is this ethics? Most of my understanding about moral spaces has been brought to me by Dr. Sabrina Darrington, and she really introduced me to Margaret Urban Walker's work around creating open moral spaces. So Walker's conception of the bioethicist role is that we can be facilitators of a social process of moral negotiation and mutual accountability, encouraging critical, reflective, and collaborative moral thinking. When I translate this into my own brain, what I sort of understand it to be is we cannot get this right on our own. We have to have spaces where we can talk about hard things, the very hardest things. We have to have spaces where we can talk about it together so that we can get it right together. So when we think about community, community is one with a shared purpose, a social commitment and interdependence, mutually supportive and accountable to each other. When we add in a moral community, we think about one in which there's moral inquiry and deliberation, where we have expression of our values, beliefs, and commitments, and where we might not always agree, but we always have space to hear each other. So what does community look like? It's dynamic, it's deliberative, constructive, engaged, curious, committed, courageous, collaborative. Moral community is not rigid, authoritative, conflict avoidant, apathetic, isolating, or divided. Sometimes ethics meetings, whether it be a consult, a debriefing, a meeting with family, they can start with community guidelines. So I'm going to share some that I've seen that I like. So these are community guidelines. Listen deeply to understand, ask compassionate questions, allow others to learn what you already know. Step up if you usually don't get the opportunity to have your voice heard, step back. If you usually are the person whose voice is heard the loudest, respect confidentiality. So what is said stays, but what is learned leaves with us. Be explicit when talking about discrimination. If we're worried about ableism, racism, gender discrimination, sexism, be very specific what we're talking about, and know that that's going to cause some discomfort and that we probably aren't going to resolve it in one meeting. And it's so important to take care of ourselves. If your ethics sessions don't start this way, I encourage us all to consider whether it could be helpful just to recognize that we're transitioning into maybe a sacred space in healthcare that functions a little bit differently than the traditional hierarchy of healthcare. And I think this is especially helpful because if there was a clear thing to do, ethics wouldn't be involved, right? If there was a clear right decision and a clear wrong decision, nobody would need us. We are specifically being called in because there's conflict. And the people who are in conflict are all good people trying to do a good thing. They're just disagreeing about how to do that. And so how do we help ensure that we see each other as all good people trying to do the right thing in a difficult situation? This is another form of community guidelines. So our Cultural Humility Task Force at Children's Hospital Los Angeles was thought about, could we have some sort of way of embedding cultural humility across the institution? So in educational spaces, research, and in clinical spaces, what would it look like if all lectures started with this sort of, we love an acronym in healthcare, but started with this sort of acronym? We thought, there was a lot of talk around that time around brave spaces, but we thought it's not really fair to ask people to be brave, recognizing that there is a hierarchy in healthcare, that it might be hard for anyone who's feeling vulnerable to have to then harness the energy to also be the bravest versions of themselves. Safe spaces was challenging because we didn't know that we could fully guarantee safety in the workplace. So we came up with this idea of safer spaces. So safer spaces are spaces in which we share openly, assume positive intent, foster growth and reflective practice, expect and embrace discomfort, and respect each other's experiences with humility and empathy. These are strategies to reduce implicit bias, and I'm sure you all are familiar with many of them, so I'm just going to run through them quickly. The implicit association test, if you haven't taken it yet, it's free. It's available online. You can Google implicit association test. I take it almost once a year because I teach a class, and in the class, I ask my students to take it. So then I have the opportunity to take it at the same time. I will disclose to you that I identify as a woman and a scientist. I'm a physician, and I take the IAT on gender, and every year my association shows that I associate women with liberal arts and men with science. And that's really important information for me to know. It's also really important information for the people who work with me to know. Because when I walk into a room and I'm talking to another physician, if that physician is presenting as male and white, I know that I am going to feel less confident in my own opinion and more confident in their opinion. That is really important information for me, and it's really important information for the people around me. So the second is what I just did. I disclose about our own biases. I also do that when stepping into the beginning of a consult. So I am a woman, a physician, a parent. My professional status gives me a lot of power, both within the hospital and socioeconomically. I'm English speaking. There may be, because of all of my identities and my experience, they may be perspectives that I miss. It's really important for me to seek out what I don't already know. Stereotype replacement is that idea of, the way I think of this best is when you form your differential diagnosis and you leave the room and you change the identity you associate with the person you were just talking to a different identity, and you see if your differential diagnosis is still the same. The fourth strategy is increased opportunities for contact. This literally is the I have a friend strategy. And even though, of course, we all hate it when I have a friend is said, people say it because it actually does open up their lived experience to the experience of others. So increased contact with people, media, experiences outside of your own identity. Individuation is the idea of seeing someone as a full individual. So even if we think back to that, say the color exercise that we did at top, if I spent some time and I really looked at that color red and I pictured the red on a tulip, the red on my son's cheeks when he came home from soccer practice yesterday, the red lipstick my mom always used to wear, I'm going to be more likely to say red when I see that color red because I'm really seeing the red. So that's a little bit of like a trivial example, but really the idea is how can you see what is in front of you? Not all the background noise that might be in our head that might be diverting us away from the truth, but how can we actually see the person who is in front of us? Perspective taking is sometimes referred to as standing in someone else's shoes. I don't love that because we're so lucky in healthcare. We actually have the person who is standing in their own shoes, giving their own perspective. All we need to do is listen to that. I think it's really important in healthcare that we understand that there is also a culture of healthcare. So that is another barrier between us and our patients. So our own personal lived experience, as well as our professional lived experience, makes us have a culture, experiences, beliefs, and values that may not be the same as our patients. It's so important that we use culturally and linguistically appropriate services. Oftentimes I'll hear folks say, this patient needs an interpreter. And I've reframed it to say, I need an interpreter to be able to communicate with this patient and their family, and both in terms of me speaking and also me listening. And so really putting the onus on us that we're the ones who need to work with the interpreter so that we can give information clearly and receive information clearly. So teach back is that strategy of, you maybe heard me do it up at the top. I sometimes will say like, the words are so clear up here, they don't necessarily come out of my mouth that way. Can you help me understand what you understood? And then partnership, really to understand that the person who is living in their own body probably has the most expertise in their body. So how do we partner with that expertise? Stephanie had mentioned that my early career was in global health, and it was actually in those early experiences that I fully understood how much I don't know. And this is a quote from a global health practitioner, Anup Agarwal, who says, humility is that uneasy awareness that you are in many ways still an outsider. You do not have the full context or lived experience of another being, and you do not have all the right answers. Humility is the feeling that should make you pause and listen fully before contributing. And I think what I learned in those early global health experiences is that the people closest to the problem think the most about their problem. I mean, if we think about ourselves, if I have something that is bothering me, I'm thinking about it when I wake up, thinking about it in the shower. I'm thinking about it on my drive to work, thinking about it on my drive home from work. I'm thinking about it while I'm cooking dinner. I'm thinking about my problem all the time. It is reasonable to assume that I might have some of the best ideas about solutions to that problem. Where I might need help from my practitioners is in having medical expertise to say, yep, this is possible, this is not possible. So really bringing those expertise together. The origins of this quote are unclear, but it's commonly thought to be an African aphorism. If you want to go fast, go alone. If you want to go far, go together. That's just a plug for partnership. We are not alone in this work. We cannot know everything by ourselves. We need each other to help us fill in those knowledge gaps. We also can't solve everything by ourselves, can't run around and take care of all of the patients in the way that we want. We actually have to all do this all together. I'm going to transition and I'm actually going to ask, because my voice is really, really going now, I'm going to ask for help in reading this poem. So this is a poem written by Dr. Kimberly Manning, and it's one of my favorites. And it just talks about that idea of partnership. So I'm actually going to have Angie come off mute if you can. And can you read this slide, Angie?
Yes. Bring your entire self to this space, your naughty hair and throaty laughs, your southern twang and East Coast edge, your multicolored hijabs and cultural traditions, your photos from Hanukkah and homemade matzo ball soup, your pierogies, your black-eyed peas, your vegan mac and cheese, and your award-winning hummus.
Brenda?
Teach me how to celebrate and greet you at the start of Ramadan. Show me what you wore to mosque at the end. Correct me when I assume your spouse or partner is of a certain gender or that you are. Move me from being a performative ally to a co-conspirator, one who stands up for you when someone uses your dead name and who refers to you by your pronouns, not because of optics, but because it is who you are.
Jeremy?
Push me to properly pronounce your name, to recognize that Mandarin and Cantonese are not the only languages spoken in China, and to have space in my heart to hold a piece of your pain, even when I'm already hurting. Tell me your grandfather's favorite joke in Farsi. Invite me to your 3-day wedding and have your aunties help me with my sari or intervene when I try to tie a Nigerian gele as a crown upon my head.
Stephanie?
And please sing me Las Mañanitas on my birthday, or some Stevie Wonder, or just maybe you can freestyle a few bars over a hip hop beat. Whatever feels right and true. And you.
And I will do the same. I won't hide or code switch, but instead bring my entire self into this space, broadening my life lens so that you can too. Thank you so much for your time. And these are just some readings that really have informed my thinking around this. I wouldn't even know what my favorites are, but if you haven't read Beyond Seeing Race by the first author is Jennifer James, who's just a genius. I encourage you to read that. And The Moral Determinants of Health was brought to meet my awareness through this certificate program. And I love that piece by Don Berwick. So I encourage you to start there if you haven't had a chance to read those yet. Thank you so much.
Yay. Thank you so much, Tanya. That was amazing as always. And it always makes me think and reflect on my own practice and how to be thoughtful in some of these spaces. I would love if folks who are in the audience want to post any questions in the chat or the Q&A so that we can ask our speaker. But I'll start you off with a hard one, Tanya, because I always struggle with this. I think it's so hard when you witness something that you're worried is a result of bias, whether subconscious or, just like flat out. And you don't know how to address it. If it's your place, if it's appropriate to do. I've seen it sort of go both ways, both like towards patients and also back towards clinicians, and these can be really subtle things. Like, for example, towards clinicians, I sometimes will hear, well, it would really help us to have a doctor who didn't have such a thick accent. You know what I mean? And I'm like, well, I want you to be able to understand what the doctor's saying, and that's sort of tough, but like the rest of us understand that, guys. So like, how is this? And so it feels sometimes hard to be the advocate that you want to be in these spaces, because you're sort of, as you said, like it's hard to sort of call this out because people get very defensive. And you wouldn't want to like accidentally make people unhappy or upset or offended, in especially in a workspace where you're either like working with them or they're your patients or, something. So like, what do you recommend for folks who want to be advocates in these spaces, but are like sort of worried about navigating the complex politics of a workplace?
I love that question so much, and it is the hardest of all questions. I think when I've gotten myself into a bit of hot water, it's because I've come into a situation feeling really hot. So the first step I would say is really what Dr. Song's slide showed around taking a breath. So am I coming in hot because I am feeling sort of like I need to do this for my own personal saviorism? So am I coming in to jump in and be the hero of this story? Am I coming in because I'm angry? Am I coming in because I'm feeling righteous? It's never gone well when I've done that. And it might be that in that moment, that anger, that righteousness, that frustration is exactly what I'm feeling. So either maybe it's not the right time for me to say something, or maybe I'm not the right person. If instead I can find a colleague, or I can come back another time from a place of curiosity, from a place of understanding that this good person said this thing that I didn't really understand, then I can come at it by saying, can you help me understand? You made this comment. I didn't really get it. I want to know more. Can I share my perspective? So it really, I think, starts with maybe interrogating, why am I feeling pulled at this moment to say something? Am I making it about me? Am I centering myself? Or am I really standing up for someone who I am hearing is being discriminated against? And if I am standing up for in solidarity and allyship, am I the best person to do that? I mean, sometimes I rush in and save the day, and nobody has asked me to do that. Sometimes the best person to speak about their experience is actually for me to hand the mic over to a parent or to that practitioner to be able to speak in their own voice. So really just taking a minute to say, is it me who should be speaking? Do I have the bandwidth to be able to listen right now? Am I the right person to be speaking? Should I be passing the mic to someone else? I don't know if that answered the question, but those are just my thoughts on it.
I love it. Like I feel like I want to come in hot, and then I'm like, maybe I'm going to come in too hot, and then, yeah, and am I the person who, I think that finding the balance between like, am I the person whose voice might be heard in this moment, against, am I the person who should be speaking, is always a tough one. But I love the idea of passing the microphone and trying to amplify the voice of someone else who's the person who should be listened to, in that situation. Excellent. Yeah. We have a comment in the Q&A, or a question from Dr. Kelston Ellis, who says, thank you for this exceptional presentation. I'm wondering if you do similar stage setting of safer spaces in palliative care, as there is so much overlap between our two fields.
Yes. Kelston, it's a good question. And I think, knowing you, I think similarly, like, we are the same person in all the contexts that we come across. So yes, I think creating those safer spaces in ethics, creating those safer spaces in palliative care, really in any clinical practice, is wherever there's a power imbalance, I think can be really helpful.
Excellent. Are there more questions from folks who are watching? Yes, go ahead.
I have a question while we're waiting for more to come in. Thank you so much, Tanya. This was a terrific talk and very thoughtful and provocative and challenging. And I want to I would love to get your insights into one particular area of implicit bias that I personally find to be the toughest, and that's ableism and the assumption that many of us have, most of us have, growing up in an ableist society, that certain states of being, certain conditions, certain incapacities or diminished capacities or whatever are always a bad thing. But those bodies always need to be fixed. They would be better off if they were. This whole like cluster of attitudes and beliefs that are there, and I think it comes out in medicine so much because of the very act of medicine being this assumption that we need to change something in order to get rid of some undesirable limitation or experience of some kind, right? How do you has thinking about this changed the way that you interact with every patient? When we sort of recognize everyone has a body that's unique. I don't like you don't see it now, but I have contact lenses in. If I take those out, I can't see anything. I can't drive. I trip over things, right? I'm lucky that I live in a society where getting corrective vision is legal. It is encouraged. It is, widely available. But I could imagine real quickly living in a society where, for whatever reason, the powers that be say you're not allowed to do that. It's a violation of the natural order or something like that. Or they maybe have some kind of religious rationale for it. If I was in that society, I would quickly, the visual impairment I have would quickly become a handicap that would prevent me from doing lots of things that I currently do. And so when I think about that, I'm not in any way trying to put myself at the same level of other people's experiences of disability, but I try to find ways to see the world that way. And I'm wondering if there's ways that you've learned to just not assume things about people when they come in front of you, that they either think a certain way about how their body looks, functions, the measurements that you take of it, like how they would necessarily think certain things are bad. I'm kind of spinning here a little bit to try to give you some stuff to work with. Hopefully something in there made sense, but how do you approach that dimension of bias against patients and families when you're providing care?
I first want to say I don't think I have any more answers than anyone else here on this call, and I get it wrong all the time. The way I sort of learn is through stories, which is why I'm so lucky to have learned through palliative care and through bioethics. And I remember early on in my palliative care career, a mom brought her son in, and he at that time was 16, and he was in the ICU, and she'd known palliative care for a really long time. And she told me about his life. When he was born prematurely and had intraventricular hemorrhage. And his mom shared that she was going to leave him at the hospital. And at the time, her husband said to her, "You can leave. It's fine. Leave our family. But I'm going to raise him. So either you're in it or you're out." And she said at that moment, she decided to stay. And they subsequently had 2 other children. And she said this 16-year-old who was laying in this ICU bed, who was nearing the end of his life, she said, "Out of all my children, he is the one who has given me the least trouble, who has been the kindest, who has brought the most joy. He never sneaks out of the house. I have taken him all over the world. He has visited family in resource-limited places where he has brought joy to everybody. He sings along in church. He may not be able to say more than 3 words, but they are all words of kindness." And in that moment, I realized I had totally devalued his life. And she says, "Out of all the people I know, he has done the least harm to the planet." And I was like, she's right. So why am I thinking that my life, really, I was thinking the way I live my life with my values and my cognition and my abilities was better than his life? And she was telling me that she had learned that that was not true. So I think all the time, this is being brought into my awareness that I'm going to get it wrong. And I oftentimes think, what's my role here? My role isn't judge and jury over over everything in this person's life. My role is to hear what's important to them, what their values are, what makes a good life for them, and then to see if I can bend medicine, if I can bend healthcare to get them to what they see as the best life possible. Because that's the point of healthcare, is to get people to their happiest, healthiest, best life possible. That's not for me to decide. That I need their expertise in their bodies to help me know what that is.
Thank you. That was really beautiful. If I could, something that was prompted there was just when I teach medical students in sort of basic bioethics classes, I'll often challenge them to hear the implicit meanings of certain words that are used in a clinical setting, right? And one that often is used is, such and such is indicated, as if there's an objective thing that if this is the case, you have to want, if X is indicated for Y, if you have Y, you should want X, right? And whatever that is. And I want to reject that idea that, it's necessarily the case. I mean, even with something that seems as non-controversial as like preventing suffering, on some worldviews, suffering is ennobling, is, part of the expected course of one's journey through mortal life. And like, I think it's important to not assume a certain view about even something like that, even though I do think, most people obviously want to avoid, suffering, but there are some that don't. And I think I love the way that you just presented that idea of letting them define, what they want out of this encounter. So thank you for sharing that.
I even think about suffering being such a subjective term. Suffering to me may be
Yeah.
totally different
Yes.
than suffering to someone else. So,
Yeah.
and then what you do with that suffering.
Yeah.
It looks like we have a comment. Stephanie, I don't know if you see the comment. Or I can read it, whatever.
Oh, sorry.
It's a comment with a question at the end.
Yes.
So
So this is from Ellen, our current bioethics fellow, who said, "This presentation is fantastic. Thank you. I really appreciated your naming of the hierarchy in medicine and the way it can impede or influence honest conversation around these topics of implicit bias. A place where I've noticed this dimension is very present is in charting language, often via the way it is taught or inherited. As a trainee, I struggle to envision ways to engage with this specific implicit bias when it is born from the top down. Do you see a place for ethics to be able to open up these conversations?"
Yes. I think us naming it exactly as you just did. I want to make sure I understood your comment correctly. And I know that you can't come off mute, so maybe Stephanie can help me here. I think the comment is around hierarchy in medicine with charting, that maybe someone with more power in the system writes something and then it gets carried forward. Is that what you're understanding, Stephanie, too?
My guess is that it's sort of that, and also that like the way that we are taught to document and chart on things probably perpetuates some old approaches to it. So for example, you must list this thing, or it's important that the chart contain, this sort of thing. Or just like the language that's modeled, right? So I think another one that I can think of a lot in the NICU is parents refused versus parents declined versus, parents were not interested in, you know what I mean? Like those are sort of different levels of sort of describing how much we disagree with the parents' decision to say forego the vitamin K shot. When they refused it is sort of different than they declined it versus they were not particularly interested in it, and stuff like that. So that's my best guess. Ellen, if we are wrong in this interpretation, please add more to the chat.
Ellen, this is going to sound like anarchy. I even think about it in the one-liner. Like, why am I saying this is a 5-year-old boy with congenital heart disease? Is that the most important thing that they would define themselves by? Like, what if this is a 5-year-old boy beloved by his parents, with a little sister that he's excited to get back home to, who's here in the hospital because his heart valve is leaky? I mean, it's really strange that we strip out someone's personhood so much so that we refer to them only by the thing that's important to us, not by the thing that's important to them. And I think it really prevents us from seeing people in their full 360. And when we don't see someone in their full 360, we get things wrong. And so I think about it, there's a lot of great research on documentation and bias in documentation. And even more is coming out now around that, about the words and the adjectives and how we document. And we hold all the power in documenting, right? The patient doesn't hold, now they can read their chart, but they don't hold a lot of power over what we put in there. So that's a very strange dynamic. But I would love it if patients could write their own one-liner, almost like in pediatrics, we use an all about me poster. I would love it if all patients of all ages had an all about me poster. These are the things that are most important to me. This is why I want this kind of healthcare or this kind of intervention, or why I don't want it, because these are the things that are important about me. And I wonder what healthcare would look like if we started there.
I'll just note that Ellen added a comment as you were speaking. She said, "You're dead on. These are all dimensions I am naming, the construction of clinical reality by our use of language resulting in the lived reality." I also want to share one of the comments again from Dr. Ellis, and kind of expand on it and maybe invite other ideas in the same kind of vein. She said, "Not a question, but a clear and applicable takeaway that I will implement starting today. I need an interpreter, not the patient. Fundamental and simple shift that shapes the entire paradigm of an encounter. Thank you for that." I agree, and I'm wondering if you could share other kind of places where you've kind of flipped the language to flip the emotional and or the way in which bias is either triggered or kind of muted a little bit, by flipping the kind of typical way that people are seeing or talking about something in a medical encounter, where it shifts the responsibility to us, and doesn't in some way suggest some fault or defect with the patient or the family. Are there other things like that you could share? And I'll also invite anyone in the comments as well. If you have things, please type them up and share them. I think that could be a useful part of this discussion.
I would love to hear if others have
Yeah.
strategies. Stephanie and I have nerded out before around like the term of this, and this sort of goes along, Jeremy, with what you were saying. This kid needs a G tube. This kid needs a trach. Well, what are you implying when you use the word need? Even if it's just like in quick chat, healthcare practitioner to healthcare practitioner, that bias seeps into the encounter with patients and families. Even if we're super careful about our language in front of the patient and family, we're still preloaded with this kid needs something. I feel like Kelston must also, from palliative care, have like a ton of examples where we hear
on that
this.
same point, Tanya. I think it's that I mean, people have pointed this out. This isn't some original with me, but like referring to the patient, even with a colleague outside of this direct setting, as the kid with the condition, right, or the patient with this, like the that reduction of the individual, again, who themselves is not seeing themselves as defined by what very well might be a temporary setback, or even if it's chronic or long, looking very long term, not how they see their identity, but yet,
And I struggle with
colleagues.
this because like and we do, right? Like in an 84 bed NICU, that 29 weeker with the heart, is like the way that I know we're talking about the same patient. You know what I mean? And if you
Right.
say the name, then everyone's like, who's that? What was that one? And like that's just sort of how we think as doctors. And it's not like we're intending to like, reduce them to a diagnosis, but like it's practical, and yet it does reduce them to a diagnosis.
Yeah, and I get the practical challenge, and I'm not saying I necessarily have an answer, but I think at least being aware of the way, as you said, Tanya, that this is like shaping the water that you're swimming in, that this language, even when it's not in front of the patient, is still potentially harmful or distorting in a problematic way.
This is maybe a little bit off topic, but I think it would be interesting, like as an adjunct to this conversation. We've done a curriculum for the past few years where with the interns, we call it Uplifting the Patient Voice. And it really grew out of conversations after the murder of George Floyd and in the racial justice movement in healthcare. How could we be better listeners? And so with the interns, we have them participate in a curriculum where they actually write for 5 minutes about a patient encounter that left them feeling uncomfortable. And it could be as minor as like, if you yourself right now in this moment, think about the last time you went to a patient room that you really didn't want to see. Either it was the patient or their family, or you had had a bad interaction, or something about you just didn't want to. It could be like you hesitate before you put your hand to open the door, or you kind of like delay it till the end of the day, or delay it till the next person is on service. Whatever it might be, you were avoiding that patient. So we have them write about that patient for about 5 minutes. And then we talk about biases that came up for them. What was it about that patient that felt hard? And then because we are a large inpatient hospital, we have lots of patients and families, many of who have volunteered to teach, and we pair them with a patient or a family member who has that same characteristic that was described as a point of bias. And then we have them interview that patient or family member. And during that interview, they're not allowed to ask any medical questions. They ask questions like, what are you the most proud of? What's your biggest accomplishment? What's been the hardest thing you've gone through? What have you learned in this life? And the intern walks in expecting to hear, the hardest thing that's ever happened to me is my cancer. The hardest thing that's ever happened to me is whatever health condition I have. And that's never what they hear. They hear the hardest thing that ever happened to me was that one time my sister got hurt. The hardest thing that ever happened to me is that my dad can't be here as often as he wants to. So it really is like when we're reducing patients down only to the things that are important to us, we're missing so much of their story. And so that's just an easy thing that I think we can do ourselves in asking more broad questions.
Yeah. We have a few comments that came in kind of on this point. Angie shared that this is where ethics and health literacy can work together, bringing the patient into their care. Dominique Lewis said, person-centered language is paramount to quality care. It also shapes how the child may see themselves. And then one of our former ethics fellows, hi, Candace, good to have you on, says, I struggle when I see this in the note. The patient failed the breathing test or the breathing trial. To me, it puts the weight on the patient that they did not pass a breathing trial on purpose, as opposed to their illness that they have, which means they do not have the ability to breathe without the vent support. So just some thoughts coming in on this point we've been chatting about here.
Totally agree. And actually, someone a few months ago when I had talked about this had reminded me health literacy is also loaded. Why would we expect patients to be literate in our field? Maybe we are illiterate in patient speak. And so like even reframing it that way, I think has been really helpful to me.
I think that's great. Yeah.
I will say on the thing about failed, in doing some of my qualitative interviews of families, I definitely had a mom say like, and when they failed extubation, like how horrible that word was. And ever since I did that study, I'm now very careful to try to be like, and sometimes extubation trials are unsuccessful. Like the trial is unsuccessful, but the baby is not like the failure. And so yeah, that is absolutely one that's tough. I see another comment here. What suggestions do you have to replace using the need language? I've been struggling with this recently, and the best I've come up with is X intervention is being recommended or discussed. Any other ideas, especially when talking to other colleagues?
I don't know why But in palliative care, we always talk about 3 pathways. Apparently, there's just always 3 pathways. So this is an option, this is an option, or this is an option. And I just say it's an option. And I might say, based on everything you've told me about what's important to you, this option brings you closer to that. But these are all the options. And so then that really takes the value out of it, unless there's something that is like a clear recommendation, right? So if there is a leukemia that has a 95% cure rate, and this is the chemotherapy regimen for it, that is a clear recommendation, and that is going to be that's going to be what is offered. But if something isn't clear, then it really is an option.
Sometimes I'll frame it in terms of sort of to achieve goals that the family has set. And so if they say, you know, we really want our kid to be able to come home and live a long time, then I said, well, if to achieve that goal, your child might need a trach. But, you know, but I won't sort of come in. But I know I've heard it, and I've heard it said, you know, I've heard it in meetings myself where somebody's like, well, your kid needs a trach. And they're like, oh, okay. And then that's sort of the end of the conversation, instead of sort of saying like, we're facing this situation about what to do next. And, you know, like, let's talk about what our goals are and what sort of medical technology might be warranted to consider to try to achieve that. And you know, trying not to say the word need as much to families, because I think, you know, if you say you need, if the doctor just sort of starts by saying, well, you're going to need this, then like parents have already kind of made up their mind that this is what the doctors say we need, and it's very hard to sort of see what their feelings were, you know, independent of that kind of very biasing and anchoring statement.
Or want. I hear want come up, like, do you want us to do CPR? And then the parent will say, well, it wouldn't have been offered if the medical team didn't think it was the right thing to do. So the answer must be yes, because of course I want my child to live. So it's not a, you know, I think like, here are the options. This is what we could do. This will happen. This is the pathway that happens if we choose option A. This is the most likely pathway if we choose option B. This is the most likely pathway if we choose option C. And just really taking the need, want, value stuff out of it, because they have so many emotions within themselves swirling around about what they need and want and value.
All right. Well, I think we are just about at the end of our time, and I don't see any more comments, but we put up the explanation again on how to claim your credit for this activity. You saw a fun talk. Get the credit for doing it, please, everybody. Let us know if you have questions about how to do this, but you can see the instructions there. There's also been instructions that have been put in the chat and at the beginning of this presentation. Well, thank you so much, Tanya. I love when you come in and speak with us. It's really, I feel like I always learn so much, and I'm always so excited to have a chance to see you, and I hope to see you at a conference again soon. Thank you everyone for joining us. We are delighted for this. We hope to see you at an upcoming lecture at the speaker series. And we have exciting news if you've been watching the newsletter about our 15-year anniversary of the Bioethics Center coming up this year. And lots of other exciting things. So keep in touch with us. We love interacting with everyone, and we're excited to see you all back. Till next time.